Mycobacterium. Now, this organism is neither gram positive nor gram negative. It has a lot of characteristic features which differentiate it from the rest. It is divided into many species known as Mycobacterium tuberculosis, which causes tuberculosis, Mycobacterium leprae, which causes leprosy, and Mycobacterium aviarium intracellularly, which causes tuberculous-like diseases, and M. cancer, which causes similar effects. Now, this bacteria is quite important because its specific characteristic known as that it is known as an acid-fast bacillus. Now, what does acid-fast bacillus meaning? That its structure contains a long chain of lipids. It is present in the cell membrane. Now, these long chains of lipids is known as mycolic acid, which consists upon carbon number 78 to approximately 90. Now, this cell wall does not take normal gram stain. Instead, it takes carbofuran stain. Now, this is an important thing because when this organism takes the stains, it takes it quite rapidly. And even if we treat the organism with ethanol hydrochloric acid, the stain does not come off. Similarly, we call this organism acid-fast bacillus. Now, this genus consists upon various species, which we have already known. Mycobacterium tuberculosis, M. leprae. We'll study all of them. The first one we'll study is Mycobacterium tuberculosis. Now, this is a very slow growing bacteria and it is cultured in two mediums. The first one is Lewinson-Jensen medium, which basically consists upon egg yolk and dye such as malachite green, which inhibits the surrounding flora growth in that respective medium. Now, this medium takes the organism to grow about approximately 6 to 8 weeks, which is quite long. In order to diagnose something, the patient would already have been suffering from various classification if we wait for this organism to grow over this culture. But another medium, which is known as Becht medium, it takes approximately 2 weeks for this organism to grow, but this is still quite long. We'll discuss various other identification points when we get to the lab diagnosis for quickly diagnosing it. But as far as you need to know is that it is cultured in Lewinson-Jensen medium, which is a nutrient-rich medium which consists of egg yolk, and it takes approximately 6 to 8 weeks. Whereas the other characteristic of this organism is that it is an obligate aerobe, meaning that it requires largely a lot of oxygenation in order to grow, meaning that it needs oxygenated tissue. Now, where are your oxygenated tissues? Obviously, they are the lungs. And the lungs, what part? It is the apical part of the lung, which receives a lot of which has a lot of oxygen concentration. So it is mostly grown over here, or it likes to be grown over here. Then the other part is that it also grows over the upper part of the kidney. Now, it has a few virulent strains. Now, the few virulent strains grows in a serpentine-like fashion, like a snake-like fashion, whereas the non-virulent strain do not grow in such a manner. Now, another thing about its structure is that we know that the cell wall is made up of lipids. Now, this lipid is also apart from this lipid which is present in the cell wall, because that stain was actually present in the cell membrane, the cell wall is also made up of lipid. Now, this lipid is known as phytoserine dimycoserosate. Phytoserine dimycoserosate. Now, this is required for pathogenesis in the lungs. Now, it causes diseases basically in the lungs. Apart from that, it also consists upon few proteins that are antigenic markers in order to detect this organism in the body, and these proteins are also used to identify if the patient has or had tuberculosis. Now, we acquired this bacterial these proteins and grow them as purified protein derivatives, and then we inoculate them into the skin for a few weeks, and we look at this, we measure the size of it in this iteration. If the size of this iteration is 15 millimeters, that is specific that Mycobacterium tuberculosis is present within the body or had previously been present. If the iteration lies between 10 to 9, there is a high risk possibility of this organism being present, but it is not clear yet. And if it is less than 10, if the iteration size is less than 10 centimeters, meaning that it is not present at all. Now, the other special features of this organism is that it is resistant to acid, alkali, and it cannot even dehydrate. Meaning that even if you use soap such as containing nitric oxide, hydroxide, the detergents will not wash it off. It will not kill it. Even if you spit and it consists upon this organism will continue to grow and will not die off. Similarly, it will again go into the air and infect somebody else. Now, the resistance is that we know resistance is continuously developing in our society because of a lot of things. The resistance in this organism is due to chromosomal mutation. Now, chromosomal mutation, we know that it is because of the transference of phagosomes that transfer the genetic material to the next bacteria, but in actually plasmids. So in this, they do not have plasmids that give the genetic material from one bacterial organism to the another, that you should be aware of this drug and it will cause you damage. Instead, in that single bacteria, there occurs some genetic mutations which cause it to be resistant, such as in the DNA, it consists upon catalase peroxidase gene, that if it is not properly functioning, we will have a resistance to our drug isoniazid, which is one of the principal drugs against Mycobacterium tuberculosis. Another is the gene mutation for mycolic acid, which is present on the cell membrane, which gives it specific, helps them to differentiate it, provide it specific color, stain, which is uptaken, which we have studied previously. Now, always remember, this organism does not have an exotoxin nor it has an endotoxin, and this organism lives in the reticuloendothelial system, which includes the spleen, the lymph nodes, somewhat similar. Now, the last important point is that we have a gene known as NRAMP that makes NRAMP proteins. NRAMP gene makes NRAMP proteins that are located in the membrane of the phagosome that play a role in determining the resistance against Mycobacterium tuberculosis. Now, what happens is that we have a gene. Now, this gene is known as NRAMP. Now, what happens is normally this Mycobacterium tuberculosis enters macrophages. Now, this macrophages can be present anywhere. Inside the macrophages, it resides inside a vacuole. Now, this vacuole normally combines with lysosomes. When it combines with lysosomes, this would obviously cause degeneration of that respective cell. But the Mycobacterium tuberculosis makes certain type of proteins that prevents from lysosomes to being attached by the vacuole. Similarly, the degeneration does not take place and it survives and it replicates. So basically, the survival of this organism, the phagosome, depends upon this NRAMP gene. If this NRAMP gene is present inside, if it is functional, the phagosome would not combine with the lysosomes, and similarly the life of this organism would be prolonged. But if there is mutation of this gene, the phagosome would combine with the lysosome and the bacteria would die off inside the macrophage. Now, looking at the pathogenesis, what we know is that this organism is entering your body by aerosols. This is your lovely mouth, this is your neck. The organism entered by aerosol. It went through the bronchus, through the trachea, to the bronchus, to the lungs. Now, when it enters the lungs, what happens? This organism is taken up by the macrophages. Now, by macrophages, it resides in a vacuole. Now, this vacuole does not combine with our lysosomes. Because why it does not combine with it? Because it has a specific protein that is present on its surface that tells the lysosome, go away, no, you're not coming near, you're not going to kill me. So what is this protein called? It is called exported repetitive proteins. Like exportative repetitive proteins are made, which prevents it. Hence this organism survives and it replicates. As it replicates, two types of lesions are formed in the respective lung. One type of lesion is exudative lesion and other is the granulomatous lesion. Granulomatous lesion, this exudative lesion is actually the initial lesion which is formed by the organism itself. Now, this is due to acute inflammation of the respective area, so exudate is formed. The other type of lesion that is developing from this organism itself is granulomatous lesion. Now, granulomatous lesion consists upon a granuloma which has a caseating center, meaning it has a caseating necrosis in the center. So it is surrounded by a giant cell which is also known as Langerhans cells, and it is surrounded by epithelial cells, which is again this whole of this complex is surrounded by fibers that give that later on what helps in fibrosis. Fibrosis later on leads to cavitation formation in that respective area. So the next step is that when a granuloma is formed by such cells, this undergo a lot of processes. Later on they fibrose, and after fibrosing they calcify into a hard material, and after calcification they leave a cavity which can be seen upon X-ray in the lung, which we'll see what a cavity that is left behind by going through all of these stages. Now, what happens if a person has taken the mycobacteria inside and it is producing a lot of lesions? Now, how is this bacteria again supposed to infect somebody else who this person will now be coughing on? So what happens is that this exudative lesion drains into a lymph node. Now, by draining into the lymph node, this complex of exudative lesion and lymph node, primary lymph node where it is drained, is known as the Gowon complex. Normally, the primary lesions form in the lower zone. Now, this is the upper zone, and this is the upper zone, and this is the lower zone. Normally, the primary lesion forms in the lower zone, but the lesion that gets reactivated somehow after the immune system has been compromised, because the organism already consists upon dead debris of this organism, but which is not completely killed. When it gets reactivated, it goes to the biopsies and go through similar process all over again. Now, the spread was because what happens, the tubercles, basically what happened, the tubercle eroded in the bronchus and they spread by aerosols. Like we previously said, the tubercle eroded and it was present in the bronchus, and when the patient coughed again, it was spread to the other human, and similarly it cycled, the whole thing repeated again. Now, another thing is that it can also disseminate from the lungs. It can also go to the rest of the body by blood. It can go to the liver, to the GIT, and cause various symptoms. Now, the primary symptoms when it occurs in the lung is actually, it starts as a low-grade fever. The patient is fatigued. There's weight loss, there's night sweat, there's cough, and there's unilateral lymphadenitis. Whereas when the organism becomes disseminated to the rest of the body, we call this thing as miliary TB, meaning that it has gone all over the body. If it affects the GIT, how will it affect the GIT? Basically, what you did was this organism is present here, you coughed, you had sputum that already contained this live organism, and then you swallowed that sputum. Now, what had happened? It entered your stomach. From the stomach, it went to the small intestine. Now, what it even enter the large intestine. Now its favorite place is actually the cecum, which is the junction of the small and the large intestine. Now here what happens is a lot of inflammation occurs, there is a lot of thickness, it looks like you have an appendicitis, but it is actually the pain, the dull pain is from your the tuberculous organism that is causing inflammation over here. Now apart from that, you can also have diarrhea, abdominal pain in the right lower quadrant, which is primarily occurring at the cecum. Then the other thing is that it can also go to the bones. Now the specific bones that it goes to is your vertebral column, especially due to your lumbar spine. When it affects the lumbar spine, what it does, it degenerates them. As it degenerates them, a lot of dead caries, your psoas muscle is present over your lumbar spine, which is going down to your pelvis and attaching to your femur. Now this dead debris goes along the fibers of the psoas muscle and deposits within them. Now this psoas abscess is known as Pott's disease. Whenever the person's leg is flexed and internally rotated, there will be a lot of pain in the psoas muscle as a dysfunction, and this will be due to the abscess created by the dental caries that was formed by the TB to the spine. Another thing it can also affect is the kidneys. In the kidneys, what TB causes, it affects the upper lobes and it results in lots of blood known as hematuria and a lot of pus, which is dysuria, pyuria, and even flank pain. It can go up to the brain and cause symptoms such as meningitis, because it affects the meninges of the brain, which is the outermost surface there. Now, how would you diagnose it? The first thing we do is we do staining of this organism. We know that it takes carbofuran stain, and this is specific. Other stain is Zn stain or Ziegler-Nielsen stain. Or also we can give the patient Quinoan version, or we can stain the sputum with Quinoan version and we'll find the organism. We can culture this organism again on Lewinson-Jensen medium, but it will take a lot of time, approximately 6 to 8 weeks. So instead we can use a Beck medium, which approximately takes up to 2 weeks. That's quite smaller than the Jensen medium, but this is our basic medium on which it's normally grown. If the organism is positive, this is only to determine Mycobacterium. Now Mycobacterium, in order to identify which species actually produced it, we do a biochemical test in order to determine which type of Mycobacterium is present. Now Mycobacterium tuberculosis produces niacin, which is vitamin D3, and it can also produce catalase, which is not produced by all of the other organisms, which is Mycobacterium leprae, etc. Now for a rapid diagnosis, because obviously this is taking some time, which we still do not know it's TB or it's leprae, and this is also taking a lot of time. So we do a lot of rapid tests, which is known as NAT test or gene expert test, in order to quickly identify ribosomal RNA, DNA from the sputum, and by similarly we can give the patient adequate treatment in time. Now the other thing is that we also need to know, because with time there is a lot of resistance created. It can be multi-drug resistant or even XDR. Now what happens is that in order to identify the sensitivity to which drug is the organism is sensitive, we do a molecular testing. Now the molecular testing consists upon luciferase assay. Now in this what happens is we detect gene mutation against the catalase, which is specific for detection if the organism is susceptible or sensitive to isoniazid, and we can check for gene mutation in the RNA polymerase, which is mutated if it provides resistance to rifampicin. Now going towards the treatment consists upon isoniazid and rifampicin, and that is given for 6 months, pyrazinamide and ethambutol, which is given after 6 months for about 2 months. Then you also need to know, after you're given these drugs, your sputum becomes non-infectious about 2 to 3 weeks. The organism is metabolically inactive, but can be reactivated if the patient is immunocompromised. So don't think you're completely cured. If you're immunocompromised due to certain cell-mediated responses that are suppressed because of certain drugs like steroids, this TB can always be reactivated. Now, in our multi-drug resistance, what do we start? We use 4 to 5 drugs. Along with this, if some of the organisms are resistant to it, apart from that, we start with the rest of the drugs. And with addition to ciprofloxacin, we give auramicin, etomidate, and cycloserine. Now, new drugs for multi-drug resistance that are being discovered discovered in 2013 is bedaquiline and diarylquinolone that inhibits the ATPase synthase. Now, it inhibits the ATPase synthase. Now, our last point is latent TB. Latent TB is actually asymptomatic infection that has previously occurred but has gone unnoticed. But it can be reactivated any part in life, which will show a lot of physical signs and symptoms which are much severe than the actual disease, because your immune system has been compromised. When immunity shut down, this again gets reactivated, and now it will form lesions in the apices of the lungs and later on cavitate there. Now, this especially happens in patients who are diabetes mellitus, because their automatically immunity is quite less, and can also happen to AIDS patients when they are treated with HART therapy. HART is highly active antiretroviral therapy, especially for AIDS patient. Now, what it does is it causes an explosive reaction which is known as immune reconstitution inflammatory syndrome, in which what happens is CD4 cells are upregulated and they form a lot of inflammatory responses, and by this inflammatory responses, if they get upregulated, they would cause a lot of destruction of your lungs. Similarly, it is quite worse than actual disease. In order to detect it, we do a PPD test, which is the Montauk's test, which we discussed. We did on the skin in order to know that previously tuberculosis was present, and we do an interferon gamma release assay, which consists upon quantiferon TB or TB spot test. Now, this measures the interferons which are actually increased, and if there are a lot, obviously they will cause a lot of damage. Now, the treatment for this latent TB is that we give isoniazid for 6 to 9 months and rifampicin for about 3 months. Remember that isoniazid, if it is given for a prolonged amount of time, it has the ability to cause toxicity in the liver. So your LFT should be monitored every month in order to know that the patient is not having hepatitis because of isoniazid. The another drug is rifampicin. If rifampicin is combined with pyrazinamide, it can lead to renal failure. So always give this in combination, but not along with pyrazinamide.